Well, thank you, and good morning, everyone. Look, we're either going to set the bar high or low for everybody else who's going to follow, so either my condolences or my apologies. Look, I'd love to take the credit for everything we've done, but obviously, as Deepak started, I CEO'd a lot of hospitals and other companies. I've been in the CEO role for 30 years. What that really means is I have trouble keeping a job. So let's talk about the most recent one. It's been a 5-year run. It's going great. And there's some things about it. I was looking for the little clicky thing that I'd like to share with you. Maybe they'll be useful. And I'm just going to run through. I have a big sign in my conference room that says, "Brilliant are the brief, for they shall make their point." And that's where we're going to try to go today. Now I just need to figure out how to do this. Yeah, well, IPA, successful ACO. Our IPA started with one doctor. And then it grew on from there, and it kind of took on a life of its own. But it was really by design and not by happenstance. And I also got to disclose that I work for Osler Health, got to make a living. And we're a customer of Innovaccer, and we'll talk about that a little bit too, but not about how we came to be a customer, but why. So there are pictures. Obviously, they're a lot more flattering than we are in real life. I am taller in real life than the picture shows, and a little fatter too. When we come down to it, you get to a point in your career, and you probably can't tell, but I have a few years behind me in healthcare. This is actually about 46, 45, something like that. And it's been kind of an interesting ride, but along the way, you learn a lot of things. And having been in a CEO role, first, you're a politician, you're part strategist, and I think the most important thing that you have to do to succeed in that role is to be a good observer. And observing the economics of healthcare is a good way of divining opportunity within healthcare. We all entered into this, most of us, was not for the money, but because we want to make the world a better place. And that's part of what we wanted to do, but also from the business side of me, and since I ran hospitals, I'm partially evil. From that side, we really took a look to see where the problems were and where the opportunities were. When you look at the fee-for-service model, it's not one that's working real well. And I know there's a lot of talk about value-based reimbursement and revenue push, and we can go through all of that stuff. But really what it boils down to is the economics of healthcare in this country. And when you look at a problem, you see a $3 trillion plus problem. Healthcare is now costing a little over $10,000 for every man, woman, and child. Whether you're here documented or not, that's what it's costing. It's more than double the next most expensive developed country. But when you look at the quality metrics and the performance metrics, we're languishing in the United States amongst the bottom in the so-called developed countries that are in that mix. So we're twice as expensive, and we're really not very effective. And when you look at the causative factors, look at fee-for-service model. It's really a treat for a task. And it's not a bad thing. You provide a service, you get paid for it. Whether it's fair, unfair, or in between, that's how it's working, and that's why there's this fit and start movement to value-based care. So that provides a different metric of financial incentives. Instead of being paid for your time, which is finite and limited, you start being paid for a delta in between a budget, a cohort group, an expectation, and what you really do. And that delta whenever you're dealing in larger organizations, can be very large. We, for example, are managing about $2.1 billion in total cost of care. Well, 10%, and even if you're sharing it with someone, is a pretty good amount of money, but that's also coming at someone's expense. Looking at the ACOs that are out there, the track record is really not very good, particularly in the Medicare Shared Savings Program, whether it's track 1 or track 3 or anything in between. And I think there's a reason for that. How many people are hospital ACOs here? Okay, a lot of hands just came up. There's an inherent conflict of interest. And I'm talking only from my experience as a hospital CEO. There is no way I'm going to cannibalize my revenues when I have tens of millions or hundreds of millions or billions of dollars of infrastructure and payroll to pay to share it with somebody else. You just can't do that. It's not presently a reality. It's a great goal, it's an aspiration, but we're going to have to do some things to get there. Now, whenever we reduce the cost of care, even if we're increasing the quality of care, somebody's going to lose. It's coming out of somebody's pocket. And we'll explore a little bit about how we're doing that. And I promise to be brief, so I'm going to try. Osler is a confederacy of independent physicians. We don't affiliate with any hospitals, but we work with them. We don't affiliate with specialists. We're primary care based. That means that everybody we deal with effectively is a vendor. And it doesn't have to be a negative connotation. It's actually, in a lot of areas, pretty positive. But we've grown in 5 years from that single doctor in our little IPA to a commercial and Medicare ACO to managing about 5% of the state of New Jersey's population. That's the point you get to be taken pretty seriously. 20,000 admissions and discharges every year in a very concentrated part of the state. We're in 9 out of 26 counties, but where most of the population in the state is. We got about 4 dozen locations. We have about 125 doctors, all primary care, and when you expand that out, there's really a lot of folks now involved in this project. But that creates challenges, and the challenge is making it work. You want to deliver ultimately high quality at a lower cost. And we have done that by using technology, not as a solution, but as a tool. And no matter how good a tool is, you have to be able to use it right. You have to be able to use it effectively. When you have a hammer, the old adage is, everything looks like a nail. Well, a hammer in the hands of a carpenter can create beautiful furniture, create a home, or make a lot of dents in a piece of wood. It just depends. So we have everybody using these tools, but it takes training, it takes support, and it takes continual reinforcement to make it work. And there's certain things that we concentrate on in how we use these tools. Understanding that a little over 75% of the cost of care in commercial populations is due to chronic disease. 96% of the cost of care in Medicare populations is chronic disease. So if you really want to move the dial and move and improve health status, you focus on chronic disease. And that's where we focused our use of technology. So value-based care, everybody, data, you turn the data into insights, you turn the insights into actionable information. That's a standard pathway, but getting along that pathway and turning it into the ultimate thing called actionable information isn't just producing a lot of really fancy reports that when you get them out into the field, the drool is coming from the right-hand side if you're right-handed and left if you're left-handed, sometimes both sides. You need to make it useful in such a way as it fits the way medicine is practiced. And at the practice level, medicine is practiced by tasks. Medical practices are very good at performing tasks. So what you do is you take all of that massive data, you turn it into analytics, you turn that into reports, you turn that into compressed, task-based projects, whether it's closing gaps in care or whether it's using sophisticated artificial intelligence to create predictive analytics. No matter what, if you can go into a practice and say, here are 25 patients who were at risk that we've identified using all this fancy technology, would you please contact them and bring them in for an evaluation? You're moving the dial. Where a lot of people are identifying the top 5% of the sickest people, well, okay, but you're already treating those people. They're already in trouble. They're the most vulnerable amongst the population. To focus on them to reduce costs from an ACO perspective is kind of pointing in the wrong direction because you want to do the right thing. What it takes is what it takes. A better way to mitigate that is to get a stop loss and not have to worry about the finances of it, worry about taking care of the patients. It's that 20% between 75% in high risk factors to 95% are the people on the pathway to becoming the next 5%. Focus on those and do it in manageable bites, and you can begin to move the dial. That's how we improved our health status amongst a large population to a 0.9 on a median of 1 when the average is about a 1.02. So it's a 12% delta in between the two. That didn't just happen. We focused on chronic disease, slowing its progression, stalling its progression, or where we can, reversing its progression. And that's how, while the line is moving up with age, gender, and diagnosis, you level that out by alleviating the symptoms and working down the diagnoses. So while the population gets older, you're actually getting them to be relatively healthier at the same time. That's effective use of data as a tool. So we had a particular challenge. We want to get all this stuff done. But again, a confederacy of a whole bunch of practices, a lot of doctors, everybody rowing in a different direction, everybody having their own bird cage and having it decorated a little bit differently. So we've got 14 different EMRs, 17 different versions of those. When you add it all up, that's a big problem. So how do you get clinical data onto a single platform when you're not in the position of getting everybody lined up on the same EMR? And even then it's problematic because there's structured data, unstructured data, it migrates all the time, the vendors always trying to protect their turf by moving stuff around to make it very hard to migrate, which means it's hard to pull out. You need somebody who's capable of doing the heavy lifting. And that came down to finding someone that not just said that they could do it, but that could do what they say. And that's how we led ourselves to getting to this point where we selected Innovaccer and we're one of their earliest customers because they said that they could do this, but they showed that they could get the job done, and they did it in record time. I'm not being a commercial here, but look, if you don't have the right partners, having all that data amongst hundreds of thousands of patients, and you want to blend that with claims data. You need a good, strong analytic program. We selected Optum for that, for better or for worse. So far for better. But getting the data into that analytic engine is, the engine is only as good as the data you feed into it. And we selected a good partner to do all that heavy lifting with a really hard job. And that powers everything from our patient engagement to our practice engagement, physician engagement, and all the other things that you need to do to take what you do and get it to the people you do it for. So everybody talks about patient-centered care, putting patients in the middle of all of your care. Well, yeah, you have to do that, but how do you do it? How do you get it done right? And again, you do that by engaging patients and having the right tools that are available to you and using them in the right way. That's a lot of planets that have to line up to have a solar system. So I'm going to just kind of gloss over this a little bit and leave it to questions. I can tell you how we did it, what's worked, what hasn't worked, and I'd rather tell you what you want to know rather than tell you what I think you want to know. So we've done good. We've done well while we're doing good. And that's pretty much what everybody aspires to. And we did it by doing this stuff. And rather than reading off of that or trying to tell you what I think, again, let's just open it to questions and see if there's any response I can give you or share some of the lessons we've learned. Yes, ma'am.
So you had all these different EHRs.
Yep.
And you pulled data from the EHRs and the claims data, I assume, to try and integrate that and then push something back out to the EHRs? I don't know.
Well, no. The interoperability with that many EHRs is, I mean, that's worse than herding cats. By the way, herding cats is not hard. All you have to do is find the food they like and move it and they'll come to it. It's not that easy. So there's no bilateral translation. We're going to have to get to a different platform and evolve further. But the goal of blending clinical and claims information in an analytic platform and then transforming that into task-based information that we can feed back into the practices to get the job done that we want to have done or that they have to do. That's a little bit easier, and that just takes some planning, but it also takes a lot of work to harvest all of that data. You know, the old adage, garbage in, garbage out.
So you physically take the findings to the offices?
We do. And rather than just supplying care coordinators, and again, focusing on that 5%, we take the information to the offices. We pay them to have care coordinators on site that are integrated into the staff and work with them on a day-to-day basis. And our job is to get out there, educate, support, and train. And we do an awful lot of that, and it's worked out really well for us. Yes, ma'am. Well, we're talking about Optum.
Did we hear the question?
Oh, she's asking if, when I started off saying everybody's expected to use our platform. Well, everybody in the support team is using the platform. And they're using it to create task-based, actionable information to feed back into the practices. So all they have to do is not think and read big reports, but perform tasks. And we have, physicians on committees that are looking at everything from finance to best practices. and giving guidance along that way. But the main task is to say, here's a list of things to do, or here's a major task with all the list to it. Click off all the boxes and you're golden. And when you have that kind of limited expectation going back to a practice, it's something that they can consume, execute, and it's to the betterment not only of the practice, but to the patients who have been identified as needing a little bit of additional assistance. Yes, sir.
What time period does your data create?
Well, the clinical data is in real time. And real time meaning within 24, 36 hours we refresh it, or maybe in some cases it's a week, depending on the immediacy of it. And that's all fed into a master program. So it's mapped, it's parsed, it's translated, it's put into a single language, it's fed up into the analytic program. The claims data comes in monthly, and it comes in from all of our payers. So we're getting it from everybody from Medicare to Blue Cross Blue Shield. So that's a monthly update.
It's 90 days.
Well, considering a claims run out, but we have begun to use imputed claims as opposed to paid claims. Imputed claims, we can take what's been billed with the presumption that it's going to be paid. And we're talking about 3 or 4%. It's not an immaterial amount, but for our purposes, the statistical significance of an imputed claim as opposed to a paid claim is not all that great.
Do you use imputed claims for hospitalizations as well? Or
We do, yeah. Everything from, we draw in information from a lot of disparate sources. So we have laboratories that are sending it in. We're looking at all of the claims associated with our NPIs, with our patient numbers, with all of that kind of stuff. And we're rolling that in, again, into a master analytic program. So we have a pretty broad picture of what's happening with all of our patients. And if you have powerful enough analytics, you can determine what you want to look for and have the reports come out for those findings. And you find some interesting things. I'll share one thing with you. Chronic back pain is a big expense for us. It's about $158 million a year. And it's also associated with opiate abuse and depression and all kinds of bad things that lead people down the road to comorbidities, to polymorbidity, to all kinds of bad things. So it's something we want to focus on, and we took a look at something simple. Using all this powerful stuff, the simple thing that we looked at was who does a better job? A chiropractor? And we're coming from the allopathic side of medicine, so that's kind of questionable. But who do patients respond better to? Chiropractor or physical therapy? So we took all of those patients, thousands of them, who only saw a chiropractor, and thousands of patients who only had physical therapy, and said, who's doing better and who costs more? Well, the results were pretty interesting. The patients who saw a chiropractor and got manipulation were half as expensive and had less comorbidities, felt they had better outcomes, felt better. And is it because the manipulations are effective, or because they got a lot of TLC and somebody saying, we really care about you and got a lot of attention, compared to only physical therapy? And we're talking about $46 a patient versus $86 a patient just for that treatment. When you look at it on an episodic basis, over tens of thousands of patients over a year and 2 years. Chiropractic with chronic back pain was lower opiate use, lower NSAID use, and $201 per patient per month less expensive. I mean, you can't, those are numbers that are hard to argue with. So, like it or not, we started to embrace chiropractic a little bit more, at least start to look at it, and started to integrate it into our clinical programs with the doctors' cooperation. And it's a program that's working out for us, and it saves tens of millions of dollars a year. And we have happier patients. That's the kind of thing that using analytics correctly can do for you, but you have to begin by asking the right question.
Do you have any statistical relation between the imputed and the claim?
With respect to the difference between the imputed and the claim, it's about 3 or 4%. And you know, again, the statistical significance for our purposes is really de minimis. So we're okay with it. And it speeds up the process. You just want to have that real-time information and real-time data, so we're hungry for that. Yes, ma'am.
The payers who provide you the claims data,
Uh-huh.
do you have ACO contracts with all of them?
We do. Everybody who's significant. And we have a lot of attributed patients. And, you know, when you look at the commercial population, it's about on a cost PMPM basis, less than half of a Medicare population. So with Medicare, you can have a smaller population and work with bigger dollars, bigger delta, and more opportunity. But we've managed to thrive with commercial as well. And we've actually changed how we contract with those commercial entities. It started off where everybody's trying to figure it out with a cohort group and balanced out with relative risk between the two, and you know, a bunch of other factors, and it was really this Rube Goldberg type of construct and putting everything together. And then we discovered, much to everybody's dismay, that if you're really doing your job and you're impacting relative risk in a positive way, you're hurting yourself. Because if you're taking what you spent times 0.9, you're closing that delta and costing tens of millions of dollars. So what we've done is gone from total cost of care to total medical expense, and balancing against ourselves with a negotiated trend. Now the dollars aren't as big in between, but at least we know what we're doing, and it's an empirical process. And you know, all the doctors getting big checks every year is still an okay thing, because then it happens reliably. Yes, sir.
Given that your network is a PCP network, what kind of relationships do you build with the specialists? Do you leave that to the PCPs to do their own, or
Nope.
do you guys structure that relationship? Are you in the middle of managing referrals too?
Well, we're not in the middle of managing referrals, but again, it's a herding cats theory. We spend a lot of time looking at relative utilization. And that means we're first taking a look at transitions of care. And one of the first things we do is take control over transitions of care. 20,000 discharges is a lot every year. And you know, a specialist has them in there, usually employed by a hospital. And once they have their control of the patient, a lot of times, and sorry hospital people, that patient is cycled through a churn and they're off into the wind. So we had to take control of that. And we just want to manage the process. We also watch relative utilization. And there are physicians, specialists, who can take episodically a population of patients and get them out with less post-operative infection. They use less resources. They have better outcomes. And those are the doctors that we identify, the specialists, and we focus on, and we concentrate our referrals to them. And when you're concentrating referrals like that for as big as we are, that's leverage. So effectively, we're treating them as vendors But it doesn't matter who they work for. In fact, it doesn't really matter to us whether they're in network or not. What matters to us is they're going to take that average $28,000 case and bring it in for 22 and do it reliably. And they are in our business. Yes, ma'am. Oh, I'm sorry. Go ahead. Yes, ma'am.
So how did you measure the efficiency of the specialist?
Well, when you have the right data coming into the right analytics program, you can take an episode of care and take that over hundreds or thousands of people and then see who provided that care from a specialist point of view. And also you can parse that out to a hospital system, a particular, even down to imaging, to see who's using what.
What did your physicians say as you showed them the efficiency of various specialists? Were they inclined to move their patients there, or did they still want to use
Without having to use the expletives, it's the usual response whenever they find out that the guy they've been referring, or gal they've been referring to for years has been really misusing resources, is betrayal. So we let that handle itself. All we do is present the facts. And the physicians look at that and say, you know, I had dinner with this guy, I played golf with this guy, but that's the last referral he ever got. And we moderate that by saying, look, you know, you have a working relationship. Why don't we set some standards and help this doctor to improve and use this other one as an alternative so we can focus things in there. We don't care what they do with everybody else, we just care what they do with our patients. So we set, and we created what's called the Osler Select Osler Center of Excellence program. We empirically require our participating practices and physicians to meet a set of 28 different metrics, from access to care to quality of care to participation in the program. And we've expanded that over to specialists. And that has to do with requirements for access to care. Because, you know, when you're referring somebody to a specialist, it's for a particular reason, and they're getting to see them 3 months later, well, that condition is going to age like milk on a hot day. So you don't want to do that. But to communication, to collaboration, and that extends not only a special designation to that particular specialist, but it impacts their referrals and the quality of referrals that they get, not only from our network, but from pretty much everybody else. So that's proven to be very effective for us.
So we have just a couple, maybe 3 minutes left, so maybe wrap up with one or two more questions.
Okay, yes, ma'am.
How do you manage discharges when you're not in the hospital to the hospital setting and accessible places where perhaps
That's a great question. We created our own physician at home program. So it's called Osler at Home. Our doctors write the discharge plans whenever that patient is admitted. Our doctors follow it through. Our doctors enforce the discharge planning, and our patients go where we want them to go. That is transforming primary care from service providers and gatekeepers to clinical managers. That's been a heavy lift, but if you're really looking for our secret sauce, that's it.
how do the hospitals react to that? Do they like to manage that through their case managers? And so
Well, that's when somebody like me goes in and I sit down with the hospital CEO and say, look, we admitted 6,000 people to your hospital last year. If you want that to continue, you're going to work with us. We don't care what you do with everybody else, we care what you do with our people. And that limits the exposure and the damage to it, but it gets the job done for what we need to get done. And I understand, it's, you know, hospitals, Look, I ran them for a long time. They are hotels with a bunch of equipment and people in them. They can't distribute an aspirin without a doctor's okay. The hospital is not the caregiver. It's a tool, it's a median, and it's only for acute care. And that's our attitude. Okay, one last.
Have you partnered with any ASCs to keep patients out of the hospital for, say, total joints, that kind of thing?
Yeah, we have. And it has been, it's had limited effect, honestly. We're doing what we can with it, but we're still feeling our way through it. I wish I could give you a more definitive response, but that's where we are today. Okay, I think it's time to wrap this up. Thank you all. I'm going to be hanging around a little bit longer. You can tell I'm from the South with the y'alls. Sorry for that part of it.